My name is Jocelyn Mjojo. I'm one of the clinical teaching fellows in HCOLL at NUH. My presentation is on patient-based teaching on Teams, and it's a replica of bedside teaching. So I'll talk about my experience. And I just want to thank the team that enabled me to do that, Dr. Rajesh David, Dr. Rosemary Arnold, and Amy Gibson. So initially, HCOLL is supposed to be 5 weeks, but with COVID coming, we were covering it in 4 weeks. And that meant that we were supposed to just to do word-based sessions. We lost our teaching, classroom teaching, we lost our IPL sessions, and we also lost like clinics. It was well when the two of us teaching fellows were working on the ward. However, I had a risk assessment and then discovered that I was 84 years old and at very high risk. So I could no longer go on the wards whereby I would be teaching the students. So the option was to work from home. But again, as a team, we discussed and agreed that we will not provide any online sessions as well, because there was already a lot on Moodle. So after some thought, I decided to create a session which was going to involve students and real patients, but still, because I'll be working from home, that was going to be another online session, but very different because students were going to generate all the information. So I called this patient-based teaching. So on the first day of our attachment, I would send emails to all the students with instructions that they needed to collect histories, take histories from patients with any geriatric syndromes like continence, falls, delirium and polypharmacy, and then they will email me that information at a date that I would stipulate. So say, for example, this is what the student would send, their email of their patient, and I would also tell them to come up with a problem list. So on the day of the session, then again, the student will just briefly present to us, and then we'll review the session together, the presentation together, and then later on, I would now talk about one of the assessments that we do in HCOLL. We'll discuss that. So with that, we'll take the students' presentation or their history and apply those to the domains of the comprehensive geriatric assessment, and we'll also come with a problem list. So for example, this patient, we discussed, and I'd already seen that the problem list, I would just call this frailty syndrome because of the way the patient was presenting. So this gave an opportunity to talk about frailty syndrome, defining it, what it is, and then look at the types, and then also look at the presentation. So we'll be matching the presentation of frailty syndrome to our patient. So for example, falls, so that opened a discussion on us to discuss regarding falls, sequencing of the falls history, and also looking at the intrinsic and extrinsic factors in the patient. Again, we looked at another presentation like continence, and that would also open up like discussions on transit causes of incontinence, as well as the types of incontinence, their presentation and management. We also looked at effects of medication and the stop state criteria that we use in HCOLL. We also looked at the assessments that go along with somebody like our patient who came with some confusion. So like assessments that we do for confusion. We also looked at mobility issues and who can be involved. So at this point, we'll be looking at the holistic approach to our patient. We'll be involving now physiotherapists and occupational therapist. And I would also point to the students that they need to observe some of these assessments as they're happening on the wards. And again, another opportunity to just discuss all the general assessments. So it's like in one session, it will open up avenues for further discussions. And actually it was going on very well because all the students will be contributing. And then so like our patient here, we are seeing this patient from admissions to discharge, including the pathways that could be used and what pathway we can use for our patient and what other assessments we could use for our patient. That's what we are applying. So by looking at it, by looking at the CGA and feeling everything in place, the student were able to go back and ask, and then if they didn't understand any aspect of it, and I was able to explain aspects of it, or we're able to just share what they've seen on the wards. The advantages of this was I was using very small groups. So it would be a firm of 2 or 3. So the interaction was better and all the students had their cameras on. So not only one person was speaking, everybody was given an opportunity to speak. And we were also using patients which the students had seen. So this made like teaching more realistic. And also through PowerPoint, I was able to illustrate and relate the topics very well. It was more of a challenge to me because it took me a long time. So this is just one example of one session, but the sessions were varied according to the presentation and the problem list of the patients. So it took a long time to prepare, and I really relied on the students to see the patient. So every student had word work assigned for them. So they'll see the student, the patients there, and then give me the actual history. So those were like one of the disadvantages that I was really relying on them. The feedback from the student was very encouraging because these were the cases the students had seen in advance. So it was like, the more they gave, the more actually teaching would come and the more discussions would cover over that. And also it allowed us to actually cover a lot of HCOLL objectives in our sessions. And the teaching being tailored to the patients, as I said earlier on, made it very nice and very interesting. So in conclusion, yes, it was a tough situation, which initially I thought as a clinical teaching fellow, I'm supposed to provide sessions on the wards. It was impossible, but still using this teaching in this way made it very easy for us to not cancel any of our teachings that we would normally do in classroom, because I incorporated all that in our session. And probably other areas can use it if they can. Thank you very much.